U.S., it's a big deal for the folks in the U.S. There's a lot of history of our country around that issue. Even if you're not in the U.S., it's always a great time to start thinking and going back and thinking about what can you be grateful for? Believe it or not, that may sound silly, but it's not. There's really good science behind that. Gratitude improves your mental health, and improved mental health improves sleep. It improves cortisol response. It improves a lot of things that really drive our health. So no matter where you are in the country or in the world, be thinking about, what have you got to be grateful for? If you're watching this channel, you probably have a whole lot. You probably know a heck of a lot more about health, for example, than most doctors, at least cardiovascular health. And that's something to be grateful for. Today, we're going to be talking about inflammation. And yes, inflammation is the bigger cause of heart disease, not cholesterol. And you know, I get beat up for a lot of things, and you shouldn't go on YouTube if you're afraid of getting beat up. So obviously I'm not, and obviously we will, but this is a message that needs to get out. I get patients all the time. I got a patient yesterday. He and his wife attended. His calcium score was like, I don't know, 217, 215 or something. Back in 3 years ago, 2017. And then a year later, it was 235, something like that. His wife was a healthcare provider. She did a lot of work in terms of taking over his health. She got him on a keto diet. She tried chelation a couple of times. She did a lot of work regarding the supplements. With the diet, with several other things, she was nailing it. She got it right, and he was doing the hard work. He was doing a lot of the right kind of exercise. They were doing what they needed to do. Then, on a follow-up calcium score, it came back 350. She was devastated. She was so frustrated. And we actually started going into the labs. They looked at it. They knew about my channel. That's why they came to see me. And here was the issue. It appears that just over the past couple of years, this gentleman has developed some very significant diabetes. And he was, you know, he was beyond 60s. He was into his 70s now. And that's what tends to happen to us. The older we get, the more challenge we have with insulin resistance. Those insulin receptors start working less and less and less. It was such a relief for them to find out what was going on and feeling like, you know, she said, she broke into tears at the end of the meeting, and she said, "Doc, I'm just so grateful that we found you. I'm grateful that we found what the problem is, because we know that we can deal with this. We're already doing a lot of the right stuff." It was just so frustrating because we kept going to cardiologists, and they would just want to give us more statins. And they said the LDL was fine. That's not that LDL. I knew LDL was not the issue, but you know, they kept going around in circles on that. They just were not getting us where we knew we need to be. We feel like now we know what's going on. So again, there's a lot for her to be thankful for. There's a lot for us to be thankful for as well, as we continue to learn how we can extend our non-disabled, healthy life. Before we get into that topic, some previous topics. What a stress test can't tell you. There's a few things that it can tell you, but most of the really important stuff, like, am I going to have a heart attack? It just isn't going to tell you that. And guess what? If the rest of the community really felt like stress tests were critical for predicting a heart attack, why have they just fallen off a cliff during COVID? You've got prediabetes. Does your dentist care? You know, unless you're in the dental profession, and in a small minority of the dental profession, a lot. This hasn't been a popular video. People just don't seem to care about it. But let me just make this one comment. If you or anybody in your family has bleeding or has had bleeding of the gums when you go to the dentist, let me give you a tip. You probably have some problem with at least prediabetes, maybe full-blown diabetes, and those two are related to heart attack and stroke. Most dentists don't even mention that. Why? Because over half of adults, when they come in, have bleeding gums. So think about that. The Got Sugar webinar remains popular. Obviously, it's a really big deal during Thanksgiving. Realizing that we have sugar problems helps a lot of us motivate to stay away from the pastas and the breads and the grains and focus on other food sources during Thanksgiving. Other webinars we have, again, one of the most popular reasons for coming to see us has to do with known plaque. Not so much where people have gotten CIMT, but just like the patient that I described earlier in the very beginning. Doc, I got a positive calcium score. I don't know what's going on. So again, we can help in that space. Supplements have always been popular, continue to be popular with us. But as we know, supplements, you can't out-supplement a lifestyle issue, just like you can't out-prescribe a lifestyle issue, out-stent it, or out-bypass it. But sometimes each of these things can help in certain situations. We've got subscription programs that people can use. A lot of people would prefer to go to the routine care arrangements that we've had in the past. A lot more people, though, are saying, you know what, I really like doing the subscription program. It helps me get what I want. It helps me budget for it rather than having a major challenge anytime I need to come back and see you. The platinum, we've added a platinum care because of demand, and we're getting a lot of folks who want to go into that. The courses are available. These courses are the general core curriculum of what you'd learn on our 1,000 videos that are on YouTube right now, and they're organized in such a way that you can learn the key stuff that you need to learn. Cardiovascular inflammation, it's a course on it. In 2 hours, you can learn more than your doctor knows. Heart attack and stroke prevention. Well, I'll talk about that one in just a second. Plaque, as I said, plaque's a big deal that brings a lot of people to see us. You need to know a little bit more about how to evaluate plaque because the standards of medicine are not set up well in that space. Another place where the standards of medicine are just not set up very well is in recognition of prediabetes, insulin resistance, metabolic syndrome. And not only do most docs not know how to recognize it, they don't know how to treat it either. Again, 15, 20, 30 bucks. I don't know how much they cost these days. But just for a few dollars, we're not even talking about 60 or 100 bucks, just for a few bucks. And in 2 hours, you can learn the information that's critical to your health and fills in the gaps that your doctor's just not going to know. If you want to get all of that in one space, you can go to the Heart Attack and Stroke Prevention Conference. We covered our core curriculum there. It was a full 2-day event. Together with that, you get a lot more content in that one than you get in all 3 of the others combined. So take a look at that. That's a great way to learn what you need to learn to stay healthy. The book is coming out. We had some arguments and some debate about the cover design. A couple of the more popular cover designs had an EKG on it, but the EKGs were not scientifically accurate. So we nixed those. I was able to get agreement on that. We won't have a fake EKG on the cover. Again, the book is coming out. I can't get clarity yet on whether it's going to be another 3 weeks, 4 weeks, or 2 months, but it's on the way. And it's all about some stuff that we've covered recently. We're covering a lot of these content from the book in our YouTube live events, and we're covering them in written form in the on the website, on our blogs, we got a lot of response to the one last week. A lot of people are beginning to realize, you know what? Rather than having to listen through that and catch all that verbally, I can go to the website, I can look up the blogs, and the content is right there for me. So take a look at that. Guess what? We've got podcasts now. When Sam Francisco came on, one of the things he looked at, he said to us, look, you've got a lot of amazing content, but you're not getting it out to all the channels that you need to get it out to. One of the places is podcasts. A lot of people want to just download the audio content and listen to it when they're running or when they're driving or you name it. So we now have it up. We've got 30 of them up right now, or 31, something like that. We've got it on Google Podcast, on Stitcher, and on Breaker. The way you find them is you go to PrevMed, you search for PrevMed, you subscribe, and we've got 31 episodes right now. We're developing a system to where we'll be adding episodes each week. If you want to go to use the site, just go to podcasts.google.com or Stitcher.com or Breaker.audio. And yes, as you might, we haven't announced this yet, and I'm not sure how this has happened, but a lot of people have already discovered these anyway. So it's an area it's a big area for growth. So what we're going to do now is talk about the program for today, and that is cardiovascular inflammation. Gilbert, you want to give? So do anybody recognize these two faces here? I would not have recognized that face from some of the pictures I've seen. Many people have said he looks somewhat like David Wright. Dr. Wright has appeared on the show with us. He's a really good doc in this cardiovascular prevention space. If you've seen the series Charité, it's about a hospital built near Berlin by one of the Kaisers, I don't remember which one, during the plague. And Charité has gone on to be, that one hospital has won more Nobel Prizes in medicine than any other hospital in the world. It's done a great job. One of the more productive time periods was that time period when Rudolf Virchow was there. Virchow is credited as being the father of modern pathology. He was chief of staff for a while. He said at one point during his activities, he said, you know, I've looked at microscopes were just coming into common use, and they were discovering all kinds of things. They were also discovering a lot of things about bacteria, which makes sense if you now have a microscope and you didn't have one before. So one of the things he was looking at was he looked at the cells of people, the arteries of people that were having heart attacks. And he said, these arteries are not only full of plaque, they're full of inflammation. They've got all these immune cells. They're releasing all of this liquid. I think heart attack and stroke is really an inflammation process. This was 150 years ago. What happened? We went down the wrong path in a big way. We got focused on that the cholesterol, the plaque, the LDL. We made assumptions, and guess what? We're still doing that, aren't we? So if we would just stop, just look, just listen, just study a little bit more. Now, which brings up the picture on the right. That is Paul Ridker. He's at Harvard. Those of us who were at Hopkins like to refer to Harvard as the Hopkins of the North. Pardon the competitive jibe there. So Paul Ridker's been probably one of the biggest mavens for cardiovascular inflammation. He noticed in what's called the Wascop study, west of Scotland. I can't remember what the OP means. WOSCOP, and the WS stands for West of Scotland. It was an epidemiological study where they were looking at heart attacks, and one of the things he and Gavin Blake, Gavin is one of his colleagues in this space, and it may not have been Blake, but it was Gavin something. They said, look, they said something that we're all still quoting. If you have LDL elevated, or if you have LDL in a normal level, that doesn't seem to make a difference. The people that are having heart attacks seem to have the same levels of LDL that the people that aren't having heart attacks. And then they said, you know what, maybe this is inflammation. And then they went on to do a couple of other trials, like the Jupiter trial. If you go back and look at the Jupiter trial, and yes, you'll get debate on both sides of the issue, but really the Jupiter trial did start to make inroads into this perspective that what they saw, and statin haters, just close your ears for a minute. What they saw was whether somebody's LDL was going up, going down, high or low, if they were taking a statin, they tended to have fewer heart attacks. So they said, you know what, we do think statins are doing something here, but it doesn't appear to be coming from LDL levels. There's got to be something else going on. And maybe it's inflammation, because they were focused on this cardiovascular inflammation thing that Virchow had brought up at that point 130 years prior to that. Sure enough, the Jupiter study did begin to indicate that. You fast forward, and we'll talk about a study just a couple of years ago called CANTOS that caught the cardiology community around the world by surprise. You hear them say over and over again, wait a minute, I knew sort of theoretically that inflammation had something to do with it, but I didn't know that it had that much to do with it. So let me go back to the script here. For over a century, people have focused on LDL as being the cause of heart attacks and stroke. Familial hypercholesterolemia, FH. It helps us understand the relative importance of LDL among cardiovascular risk factors. You remember, I've got a lot of FH patients. If LDL were really the biggest issue and other things were not, we would know exactly how many people have LDL. We'd have screening programs that are out and active for LDL, because we would know that's what's causing heart attacks and strokes. Well, we don't. The vast majority, I mean, I diagnosed a lot of people with LDL, but it's still like, we don't know whether it's 1 in 200 people or 1 in 500 people. It's just, there's so little that we know about FH. The risk for FH patients is more of a decreased capacity to manage the other risks, like smoking or prediabetes. And if you don't believe that, go back and look at some of my videos. Sue was one of the ladies that gave us a great video. She had to have a bypass, quintuple bypass at age 35, 36. She had FH, but her problem was she had FH and she was a smoker. That activity got her to back off and stop the smoking. Then she started developing another problem. She did fine up until her 60s. And then she got nervous. She started overeating. She more than doubled her weight. She more than doubled her weight. Guess what happened to her insulin resistance? Guess what happens to all of our insulin resistance when we increase our body fat? She ended up going back again, having to have more surgery. That got her back on the path. She lost half of her body weight. She's now in her 70s, very happy, very comfortable that she knows what she needs to do. Despite having her FH, she knows that I've got FH, I've got a significant increase in LDL, I've got a little bit less resistance than other folks to things like smoking and prediabetes, diabetes associated with weight. So I have to watch my risk factors. But she also knows FH is not going to kill her in her 50s. I've got, at least 100 patients with FH. And that's what you see. You see as they start developing other risk factors, they have less resilience. So let's go back to the script again. Pardon me for all these bunny trails. Newer data from the 1990s began to showcase inflammation instead of LDL. Many researchers like Burke and Liuzzo strongly associated inflammation with future cardiovascular events, independent of the usual risk factors. Now here we talk about Paul Ridker, the fellow over in the picture that I mentioned. Paul Ridker and his associates showed elevated CRP levels in healthy subjects before first ever vascular events. And here's the article. That looks like New England Journal. It's not listed in there, but I'm pretty sure that's one of his New England Journal articles about inflammation, aspirin, and the risk of cardiovascular disease in apparently healthy men. So inflammation starts with an injured intima. You remember what the intima is? It's that lining of the artery wall. If you look over here, that's an image of that's a drawing of the intima. If you look here, this little piece right here is the intima. If you look on this image, it's the lining. It's a single cell layer thick. It's got a hairy projections on the inside called glycocalyx, and it's easily injured, especially from things like having blood glucose too high or insulin levels too high. What happens is you get inflammation. That's a darkening area. You get a little bit of bleeding into there. And if these dark areas, that's from the inflammation. It's where the immune system is attacking the plaque. And if those areas get close to the surface and they break through, they can cause a clot. Hot plaque is liquid. When it touches the blood, it can cause a clot. That's what this black thing is. This patient, this patient died from a heart attack. And this is only part of the clot. The bigger part of the clot is what killed this patient. It broke off and went in and stopped blood supply to a major portion of the heart. So oxidized LDL particles are trapped in the intima media space. LDL, remember? So that's why we went down that bunny hole, that 100-year bunny hole of thinking it was LDL. Plaque attracts the attention of immune cells. Immune cells release enzymes like LPPLA2, myeloperoxidase. You see here, these are macrocytes, monocytes. They're a type of immune cell. They come in, they find that there's too much plaque. They come in, they start releasing what we call cytokines. The macrocytes turn into foam cells. They start releasing plaque 2. It's an enzyme which creates some of this liquefaction. Easy for me to say, huh? Liquefaction of the plaque. And once you get that liquefied hot plaque, that's where you get into a problem. MPO, myeloperoxidase, is the same kind of thing, except it's from a different immune cell. It's from what we call a neutrophil or a leukocyte or a polymorph. You know, we got way too many names for these things, and it just continues to make it more complicated. Sorry about that. Immune cells release enzymes like plaque 2 and MPO to destroy the plaque. Foam cells and fatty streaks are also produced. Again, more of this immune inflammatory reaction. Both of these are inflammatory. Cytokines, cyto meaning cell, kine meaning attractant. A cytokine is something released by these immune cells that attracts other immune cells. So as you see, you start getting into this increasing spiral of increasing inflammation. Cytokines are released and they drive inflammation in the area. Over time, soft plaques can then rupture like a pimple. You remember we've talked about Tim Russert, Big Russ, many times with his heart attack. What they described on his path report, his autopsy report, they said, once we sliced open his arteries, the insides of his arteries looked like the pimply face of a teenager with a really bad case of acne. He had these things all over. And if you're still having a problem understanding what inflammation looks like on the inside, I just did a couple of videos about 3 or 4 weeks ago talking about, at that point I had a lot of inflammation on my face from a chemical I was using for precancerous growths. We showed the Two-Face, the Tommy Lee Jones villain in Batman. We showed Kim Kardashian. She has psoriasis. There's also a fellow named, it's not Sting, I'm forgetting his name. He's, oh well. Some of these well-known celebrities that have either psoriasis or lupus or other things that can cause inflammation on the face. Once we see that on the face, we say, oh yeah, that's inflammation. It's the immune cells attacking stuff. Sometimes though, it's just hard to imagine that happening in the artery walls. That's exactly what's going on. That's exactly what's killing us. If the cap breaks off on these pimply faced, or these pimples inside the artery, the soft plaque can rupture. It releases enzymes. It forms a blood clot. Undissolved clots break off and get pushed into the smaller vessels. Large clots stop blood flow and block the oxygen supply. If the oxygen-starved tissue is in the heart, the result's a heart attack. If the oxygen-starved tissue is in the brain, the result is a stroke, I'm sorry. If it's multiple little ones and it's in the back of the eyeball, that's when you get diabetic injury of the eye. You can also get decades of this, microscopic levels, and that can cause dementia in the brain or heart failure in the heart. Now, how do we detect inflammation? That becomes a bit of a, there's a longer story there. C-reactive protein is what Paul Ridker used. It's what most people use who actually look at this. But there's a problem with that. Common false positive rates. If we take 100 people today and give them a flu shot, the regular flu shot, 2 days later, 48 hours later, 66 of those 100 people will have a positive C-reactive protein. So as you can see, C-reactive protein, it's made by the liver, it's a response to any type of inflammation, and there's a lot of false positives. It's not just inflammation in the cardiovascular system. Now, microalbumin creatinine ratio, we also look at that because it's okay to use C-reactive protein, just one somewhat challenged indicator when you're doing global studies like Paul Ridker. But if we're looking at one patient, an N of one patient at a time, and we don't want to miss this, we need to use other tests to get a little bit better picture. Well, microalbumin creatinine ratio is a great, it's a great option as well. We add that in our inflammation panel. If the intima in the kidney filters is damaged, so here, let me go back. Each kidney is about 1 million filters with some concentration ducts following those filters. The filter membrane in each of those 1 million filters is the intima. It's what's usually the lining in the rest of the artery, the arterial trees, the arterial system. In fact, the filter is nothing but arteries that pass through the kidney, the media, that muscle layer, backs away. You've got nothing but the intima. Now that's what the filter is in each of those 1 million filters in the kidney. Now, if you're leaking protein into the urine in that filter, guess what? You're also leaking LDL from the blood into the artery wall in the rest of your arterial system. That's why we look at microalbumin creatinine ratio. The creatinine ratio is only there to help us understand how much and quantify the albumin itself. So if albumin is leaking into the urine, LDL is likely leaking into the arterial wall. Now let's talk about plaque 2. It's plaque 2 and MPO are both things that we typically look at on our inflammation panel. Sometimes they add IL-6. Most of the time they don't have access to it, but we get the picture with these four: c-reactive protein, microalbumin creatinine ratio, plaque LP-PLA2 or plaque 2, and MPO. Now, most people begin to think, well, that plaque 2, that must have to do with testing the plaque itself, or maybe it's the platelets. It's neither one. You remember we mentioned that foam cells, macrocytes, create an enzyme, and that enzyme is set up to start, what it does is it starts dissolving the plaque. That's plaque 2. We're actually measuring that enzyme in the bloodstream. MPO is the same thing, except it's not made by foam cells. It's made by the neutrophils. We can actually measure those. In fact, if you look in this picture, you'll see that there you start to get plaque 2 and MPO development right here in this stage. This is an artery, normal, starting to get plaque, increased plaque, starting to get some inflammation here. And here's a little connect the dots kind of thing. You notice these little green dots? It's kind of gross. If you get grossed out easily and you don't want to hear it, close your ears for a second. But you see these green dots? So myeloperoxidase is actually has a color to it. The color is green. In fact, if you go back, you've probably seen it. You may have some not some gross memories of it, because the place you might have seen it would be mucus. Sometimes if you have a bad cold, or if a child has a bad cold, sometimes there's a greenish tint to the mucus, the snot. Well, that greenish tint comes from myeloperoxidase. The immune cells, the neutrophils, are very active in that cold. They're releasing a lot of MPO, and that's what's creating that greenish tint. I'm not going to go into detail on IL-6. It's interleukin-6. It's a protein produced by various cells. It's nearly always elevated when we do get cardiovascular inflammation. Now, what causes inflammation? At least 80% of it's caused by diabetes or prediabetes. And I have to tell you, if I've heard it once, I've heard it 1,000 times. Doc, I don't have diabetes. I don't have prediabetes. I know what I'm talking about. My doc checks it every 6 months. And I check after him. I mean, I get that quote a lot. In fact, I have to take a break and do a little digression, because I want to share with you a slide from a patient that saw me just last week, 2 weeks ago. My doc says I've got no sugar problems. I've checked. I'm watching him. He's right. And here's what they had. This patient had a hemoglobin A1C of 5.2. They had a fasting glucose about 90. That's perfect. The doc kept saying, you're in great shape. But they said, okay, doc, I know you're crazy about this, so I'll humor you. I'll take your studies. Here's what happened when we challenged that person's metabolism. Sure, the hemoglobin A1C came out in the low 5s. It looked great. The fasting specimen, as you see here, was 94. They peaked at 1 hour at 168, and 2 hours was 124. Now, what's good, what's appropriate? Optimum would be 90, 120, and 100 or less. So this person clearly had inflammation. I mean, had prediabetes, moderate level. But here's the rest of the story. How do you control, how does your body keep your insulin down? I mean, your glucose down? It does it with insulin. We also measured insulin, and here's what we saw. Optimum levels for insulin would be 5 or less for basal or fasting insulin, 50 or less for peak, the 1 hour peak. and 20 to 30 or less for the 2-hour peak. Here's what this individual's insulin levels were. In order to keep his basal glucose at 94, he was producing 3 times the optimum level, almost 15 insulin. 10 times the optimal, no, not 10 times, 6 times the optimal level at the 1-hour peak. Optimum is 50. They were almost at 300. That's how much it was requiring to keep that level just as low as 168. And then at 2-hour, instead of down to 20, he was still up at 240. So almost what? 10 times the amount of insulin from optimal. So again, and this is from somebody who had, quote, absolutely perfect numbers. You got to stress it. You cannot just look at fasting numbers and say somebody's okay. And that's part of the point where studies have been done. Doctors don't know how to test for this. Beware, buyer beware. It's your own health we're talking about here. If you depend on your doctor to know this stuff, it's not going to work. You're going to end up with all these other folks having heart attacks, strokes, and dementia. So I'm sorry. Thank you for tolerating the bunny hole. So back to the script. In 2017, the CDC said that there are over 84 million adults in the U.S. with prediabetes. However, 90% of these people don't know they're pre-diabetic. The year before, the UCLA had already reported that, no, it wasn't 1 in 3 adults. It was over 1 in 2 adults, 55%. And here's the other thing. They also said, no, this doesn't start at age 60. We're talking about age 30 and above. Even for 30-year-olds, 1 in 3 already have this problem. So can we delay this? I mean, am I just being a scaremonger, a fearmonger? Am I just saying Rome's burning, the sky's falling in? No, I hate people that do that. Negative people. Here's why I'm continuing to cover this. There's a giant opportunity here. We can slow this down, stave this off, and save ourselves decades of healthy life. We do not have to be this concept that you get into your 60s and a heart attack or a stroke can happen and kill you like lightning out of the blue. That does not happen. It's Harvard, look it up, Harvard Health. It's not lightning out of the blue. It's sort of like real lightning. This concept of lightning out of the blue is a movie concept. Lightning doesn't happen out of clear blue sky. Lightning happens when you've got a storm. And we can find that metabolic storm, and guess what it is? It's inflammation. You know, we've known about this. I'm not telling most of you something you didn't know. Time magazine on the cover in 2004 said this: the secret killer, the surprising link between inflammation, heart attacks, cancer, Alzheimer's, and other diseases. And here's the promise right below that, and it's the promise I have too. What you can do to fight it. Now, there's been a lot of stuff about the Campbells and their China study, and you might wonder, well, Brewer, you're big into low carb diet. Why are you presenting that? Because the China study really talked about plant-based diet. They attributed all of what they saw to plant-based diets. Here's what the issue was. Yes, you did see significant health. You did see 50,000 Chinese field workers up to 80 years of age with no plaque or inflammation. Yeah, they may have been eating mostly plants, but here's the thing. Obesity was not a big issue for these folks. So if we maintain our body fat, I would say, and those of you who are very emotional into the dietary battles, I would say body fat content, body fat percentage is at least as important, probably a little bit more important than macronutrients, whether it's carbs or whatever. Now, on a day-to-day basis, clearly the most important thing is not eating carbs. But on a long-term basis, you got to get that body fat down because that drives this process. Atherosclerosis is not age, well, it is age dependent. You can get into, you know where this argument's going. It's very lifestyle dependent though. What affects the amount of inflammation in our arteries and the amount of plaque, which leads to plaque rupture and ultimately in heart attacks or stroke? It's in what we eat, how active we are, our level of stress. You remember we started off talking about Thanksgiving and finding something to feel gratitude for? And the fact that that's not just airy-fairy kind of junk, that's reality, because it actually comes back to stress and cortisol levels. Let's go next. We're going to cover 30-second clips of a couple of videos. This is going to be the video where the CANTOS study was announced, and these cardiologists across the world, I mean, it was done by Paul Ridker, and he gave an anti-inflammatory to people around the globe, and it stopped heart attacks and strokes. Let's do, I think we were going to do like 30 seconds of this one.
In 1994, we published a study inspired by Tilio Masseri in the New England, and this study put the inflammatory hypothesis of acute coronary syndrome on the map. This study simply showed that in patients with unstable angina, those with higher levels of CRP had the worst outcome. This study raised massive interest, and in the following years, Peter Libby in particular published a series of masterly studies dissecting out the molecular pathways linking inflammation and plaque fissure. In our group and other groups, we demonstrated that acute syndromes are also associated to disruption of adaptive immunity.
So, not too easy to listen to, especially if you're a native English speaker, but one of the points that you may have heard out of that was, this wasn't last year, this wasn't 10 years ago, this was 1994. This was 25 years ago. And yes, the cardiology community is finally, after CANTOS recently, starting to say, yeah, this is real. You'll hear that in this next video from this cardiologist. He says, yes, cardiovascular inflammation is real. I'm not going to cover the whole thing. In the latter part of the video, he goes on to say, but there's nothing you can do for it. What? Go ahead, show that one.
What role does inflammation play in heart disease?
A tremendous amount of literature in the medical journals have focused on the role of inflammation in cardiovascular disease, specifically the risks of heart attacks. And I don't think there's any doubt that inflammation plays a role. However, what's less clear is whether treating inflammation itself is going to change someone's risk. And that may seem a little bit confusing.
So, well, I told him he had to cut that off at that point. I watched the rest of this video, and there he goes down this path of, oh, that's confusing. We don't know. Again, it gives me a headache. Welcome to my world. That's where I live. So I think we get some sort of water ball or something. We're going to transition now from the program into the Q&A. So, Amer from Germany, thank you very much. How are you? Good to hear from you. You're very common. You're here often. We appreciate the interest. BJJ, Brazilian Jiu-Jitsu, good morning from Temecula, California. Great topic. Thanks for attending. I have to tell you, we've got 100 people here, and I'm surprised. This is the day before Thanksgiving. Things usually die down, and yes, the daily viewership on our channel is like 5,000-6,000 a day right now, and it's usually, gosh, 3 or 4 weeks ago it was between 12 and 18,000 per day on a regular basis. So we're into the holidays, but we've got a lot of interest today. Thank you very much for your interest, taking this time during the day before Thanksgiving. And yes, it's always a good time to give thanks, and because gratitude has been shown to be one of the most important things that we can do for our mental health and cortisol. Osei Shalom. I have not heard or seen that name yet, Osei. Thank you for joining us, and thank you for your comment. I get a lot of comments about curcumin. As you know, I do some work with supplements. Although you can't out-supplement a lifestyle problem, there are times when supplements make a big difference. And guess what? I personally take a lot of supplements. I recommend and prescribe a lot of them. Curcumin is one of my more commonly prescribed. It's a great anti-inflammatory. That has got to be why Osei is saying curcumin. It's an anti-inflammatory. Thank you, Osei. Or I hope I'm pronouncing that correctly. Chuck Rogers, thankful for many things, including Dr. Ford Brewer. Oh, shucks. Thank you, Chuck. I appreciate that. Bart Robinson, absolutely, Chuck. Thank you, guys. I do appreciate that. And I appreciate the interest that you guys have shown. When you start clicking on this, when you appear on here, you watch this, the YouTube algorithm is watching this behavior, and it's saying, okay, you know what? We've got some human interest, and we're above 100 now, speaking of which. And we got 1 like. Maybe you could do a few more likes. Again, send some more of this information, this human behavioral information, back to the AI, the artificial intelligence, the algorithm within YouTube. And that, in turn, will start sending this out to other people, suggesting it. Overall, if you look at our channel, about half of our views get picked up because the YouTube algorithm was suggesting it in suggested videos. Most of the other half happens because the YouTube algorithm put it on somebody's homepage. It is the algorithm. The algorithm tends to drive, gosh, at this point, 90%. It used to be 100%, and it is for the smaller channels. As channels get bigger, you start seeing buzz about things, and it gets, you get backlinks, you get mentions on forums, you get mentions on other social media like Facebook, and then they'll put links, and then you'll start getting links in from that. And this channel at this point is getting a lot of that as well. But still, I mean, we're not a huge channel. We've got, what, 78,000 subscribers. A lot of people think that's huge. It's not. It's significant, though. Even for a channel of this size, your behavior, like watching today, like staying on, like clicking like referring, especially if you take the click and you put it in Facebook or one of these other places as a link, makes a big, big difference. Thank you so much for your feedback. Ruth Dodson, throughout the body or in a specific area? So that's a great question. And here's the thing. There are a lot of misperceptions about heart attack and stroke. They think, and it's where the doctors go in and do an angiogram, for example. An angiogram is based on the incorrect assumption that a heart attack is going to occur where there's the most narrowing of an artery. That's not the case. Inflammation is not in one space. Now, there is some correlation to narrowing in the artery, but it's not what you think. It's not like a hair clogging a drain. Inflammation is a metabolic issue. Like I said, prediabetes is by far the most common cause of inflammation. Prediabetes happens throughout the body, the whole place. Anywhere your body has arteries, if you've got inflammation, it's it's getting that problem. Other major causes, like I mentioned before, LP(a), inflammation associated with the inflammatory diseases. The biggest one, most common one, being rheumatoid arthritis, lupus, psoriatic arthritis, that's the arthritis associated with psoriasis, as well as a bunch of other type inflammatory diseases. These are whole body diseases. So yes, there is some problem when you have a pinch point in an artery, but it's not that that pinch point is slowly closing off. That's what most people think. It's not a local issue. It is a systemic issue. Great point. Thank you, Ruth, for raising it. Gave me an opportunity to blab. A. Schultz, can a niacin flush relax all muscles for a while? Some people get a relaxation from it, others don't. Others just, they don't like it. They get, it makes them even more hyper. What's going on is it's release of a thing called a prostaglandin. That's like a local hormonal release, which causes vasodilation of the arteries in the area. Short answer is no, it doesn't. It could for some people, but that's not what's going on. It's not that it's relaxing muscles. Kid poker, 007. We've gotten into poker recently, and I beat Janice last night. She beat me the night before. I keep doing all this studying on poker, and I'll get an advantage on her like one night. She watches my behavior that one night and then beats me at it the next night. It's painful. But anyhow, evidently you're into that too. There's a fella called Kid Poker, Daniel Negreanu. He's one of the most well-known poker players. They call him Kid Poker, but I don't think it's Kid Poker 007. If you're Daniel Negreanu, please let us know. I'd love to find out. I mean, you're a celebrity. Anyway, can vitamin B12 reduce inflammation? Vitamin B12 is not so much an anti-inflammatory. Vitamin B12 has a couple of roles. Number one, it decreases nerve damage associated specifically with diabetes. Number two, it's one of the B vitamin complexes. The B vitamin complexes have a specific role with what we call antioxidants. You get a huge increase in the market associated with antioxidants, vitamins A, C, E. Those of us who have MTHFR, methylene tetrahydrofolate reductase problems, and that's over half of us, I'm included, we are much more likely to get into this inflammatory process because we don't have antioxidation activities as effective as the rest of the population. So in that roundabout way, these the vitamin B complex is used as a storage pool for methylation, methyl groups, and that's how the body accomplishes its own antioxidation. And as you might imagine, anything your body can do is going to be much better than you can do from outside. So having your own antioxidation, an active methylation process is far more effective than having just taking vitamins A, C, and E. Hope that wasn't too technical a digression, but it was a good question. I appreciate it. Robert Simpson, Dennis could less about diabetes. Not sure what you meant there. My BJJ, do you find that there is a correlation between lowering of LDL and lowering of inflammation with statins? We find lower, yes. So for the people that have FH, I mean, familial hypercholesterolemia, which there are about 2,000 SNPs. For those of you who don't know what a SNP is, most of it think of it as a mutation. It's not technically a mutation, but it's a genetic variation. There's about 2,000 genetic variations that have been defined so far that cause FH, extremely high cholesterol levels. For example, that's LDL, not total cholesterol, LDL, 180 or above. If you've ever had that, you're very likely to have familial hypercholesterolemia. And there's a lot of you out there. As you get into those levels and higher, you do get some challenges associated with this issue. But as I mentioned earlier, not nearly as much as what the typical medical community member thinks. So the second part of your question is this the reason why statins lower inflammation? No. So a great question, BJJ. Is the decrease in cardiovascular inflammation associated with decreased LDL? It certainly does not appear to be the case. And I'll give you a couple of reasons and examples why. One of the more effective ones, statins at lowering LDL, is that old standard, Lipitor. And I mentioned a brand name, so the YouTube algorithm's going to cut us off for advertisements on this, but it's worth it. Lipitor is great in terms of lowering LDL, but it's not so good in terms of decreasing inflammation. So that in and of itself helps you understand that these are two different mechanisms. The mechanism for decreasing that inflammation is not entirely understood. But one thing that is understood is it does not seem to correlate that well with lowering LDL. You go back to the Jupiter study, you go back to multiple studies, you go back to the example I just gave, and you look at some others. For example, here's another example. Low doses of the correct statins lower inflammation and may not have that much of an impact on LDL levels. For example, people that are on statins will typically come to me. I had one of the patients yesterday had stopped taking statins. He was up at, his doctor had put him on 20 of Lipitor. 20 or 40. I mean, it was a significant dosage. And he didn't like it. He was having a lot of muscle problems. So he stopped it. He'd been off it for quite a few months before he came to see me. Here was an interesting thing that we looked at. He had no inflammation. His LDL was what, 130, 140. It was more than what most doctors would be comfortable with. But here was the thing. His CIMT showed an arterial age of what, 35? And this individual was 61 years old. I mean, I've seen Superman in terms of arteries. And he had no discrete plaque. He had no plaque. So, he and I talked, and he said, one of the reasons I came to see you was I know your perspective on this stuff. My doc kept trying to put me on a statin. I'm getting in a lot of pain from these. I don't want it, and I'm wanting to know from you, do you think I need one? Well, I mean, most of you know my perspective. I don't think that just an LDL level is that A, that dangerous, and B, the reason to put somebody on a statin. I don't think Framingham is the reason to put somebody on a statin, and I don't use stress tests. What I look at is whether you have plaque, because if you don't have plaque, you're not going to have a heart attack. I mean, at least the kind that we're talking about. You can have some dysrhythmias and some totally different things that sometimes get called heart attack, but you're not going to have what we're talking about with myocardial infarction or a heart attack associated with a clot. You're not going to have one if you have no plaque. So my perspective was, if I were you and I had the total lack of inflammation that you have, if I have the total lack of plaque that you have, I wouldn't take it. You don't need it right now. So BJJ, I hope, again, as usual, I went down a whole bunch of bunny holes. I hope that answered your question. There is little to no correlation between lowering LDL and lowering cardiovascular inflammation. John Tocho, thank you for all that you do for us. Well, thank you. And I thank you for your attention, your interest. Again, what you're doing is helping us get out there. And if you would, guys, if you think about it, go ahead and hit it. Some of the younger generation says, look down there and smash that like button. It would help us get this message out there. James Osborne, is there anybody with medical conditions who shouldn't take niacin or vitamin K? Be very careful about what you mean with vitamin K. With K2, it's not that clear that there's significant danger anywhere. There's been one study which sort of muddied this whole issue. If you're on the vitamin K agonist, the VKA, that's like Coumadin. If you're on Coumadin, usually vitamin K2 is going to be safe as well. Coumadin or Plavix or some of those. But if you're on one of those, you should check and see if that's really the right blood thinner for you anyway. For fewer and fewer people, is it the correct thing? Niacin. Niacin is, again, it's both of these are over the counter. And I'm thinking you're talking about niacin and vitamin K2. Niacin does cause some GI upset in some people. And it does cause some increase in, it moves you down that diabetes highway just a little bit. So it's not totally harmless, but clearly for most folks, the benefit outweighs the risk. Niacin and K2. Niacin, K2, and vitamin D3 are by far my most commonly recommended supplements. Bergamot, bergamine, cinnamon, and curcumin, probably the next 4. Robert Simpson, my C-reactive protein was 2.8 last month. Well, Robert, I have had a 0 C-reactive protein all except one time. And that one time was, what, about a year and a half ago. And it went all the way up to 10. And it was like, whoa, inflammation panel, totally 0 from time immemorial. And then a 10 on C-reactive protein. I just grinned, though, because 2 weeks before that, I'd had the flu. And that's what happens. Now, one thing I would say, though, Robert, is continue to monitor that C-reactive protein. C-reactive protein is one of the important, as you might guess, I've got a lot of patients. If the inflammatory diseases are the key, one of the key significant risk factors for cardiovascular disease, I have a lot of arthritis patients. I have a lot of psoriatic arthritis, a lot of rheumatoid arthritis. And here's the thing. Typically, a rheumatologist who's following that patient with me is usually following C-reactive protein. So when I have a patient that has an elevated C-reactive protein and everything else is fine, then obviously it doesn't look like inflammation. We go ahead and we rule that out. But we'll continue to follow that. And if you've got a continued elevated C-reactive protein, you really got to start thinking about, do I have one of these inflammatory diseases and not know it? Trobolt 1, wow, pure gold. Well, I'm going to take that as a massive compliment, and I'll say a massive thank you. I've been getting a lot of feedback this week that I've got a lot to be thankful for. Thank you, guys. Ciao, CEO. So once a patient doesn't pass the GGT and insulin test, how is that treated besides going low carb or keto? Well, one of the most important things, you could say, well, I'm already low carb or I'm already keto. I don't need to know about it. Well, you could say that. One of the things you do need to know, I would think though that, well, most of my patients benefit from knowing, even if they're on low carb keto already. Low carb and keto have different variations. People need to know. Most of the time people walk through life without any kind of dashboard. We have a dashboard on our car. We want to know how fast we're going. We want to know how much gas we're burning. We want to know what our oil pressure is. This is our most important indicator of our health for the next few decades. Don't you want to know how well your diet's working? Don't you want to know how well your exercise program is working? Don't you want to know, maybe I should adjust. Maybe I should, I still have love handles here. And you know what? Maybe that's still driving some of this problem. Don't you want to know? It's a dashboard. Trobolt, thank you, thank you. This is number one pressing issue. It is, and thank you, Trobolt 1. I appreciate the interest and the acknowledgement. James Osborne, can you still calcify or shrink plaque with Uh-oh. We're getting a lot of comments here. Here we go. Can you still calcify or shrink plaque with prediabetes numbers? My numbers seem stuck in the low 100s taking metformin. Is additional medication required? Went to a ketogenic diet. Well, the number one priority is diet. Number two priority is diet. Number three priority is diet. Then you get exercise. One of the components of diet, it has to do with body fat. You need to really, again, that's what some of this testing does. It helps you understand how much of an impact things like body fat are having on you. Now, metformin decreases, we don't really understand all the different things that metformin does. We know that metformin decreases gluconeogenesis, meaning glucose newly made in the bloodstream. That's what your liver does. And metformin decreases that, but it does other things too. It impacts the gut biome. Well, how do we know that? Because you get gas and diarrhea. At least 1 out of 5 people do when they start metformin. But did you know that the gut biome is very much associated with whether or not you have prediabetes? I'm not going to spend more time going down that bunny trail, but look it up. I've got some videos on it. So metformin does a few things. The key, the root cause issue does not appear to be that much impacted by metformin, and that is the sensitivity of the insulin receptor to insulin. Now, there is a drug, while we're talking about drugs, there is a class of drugs that does that. They're called thiazolidine diones. The most common, the most well-known is pioglitazone. The early trade name for pioglitazone, and since we've blown advertising, we're just going to go ahead and mention commercial names anyway. You'll recognize it better. It's called CANTOS. That was an extremely popular drug 20 years ago. Actos is the only drug. There are two very clear ways to increase your insulin receptivity to insulin. One is losing body fat. Another is another is decreasing cortisol with sleep and stuff like that. But on a reliable, dependable, you can watch it happen basis, decreasing body fat is the most common thing that I see. The second big item I'll see is the people that start Pio. Now, Pio, it's a prescription drug. It's got some significant side effects. One of them is it's been associated with bladder cancer. It's been associated with some water weight gain. So you should take 2 or 3 looks and investigate deeply before you go on to something like Pio. I will tell you, I take it. I don't take it every day. But here's why. The probability of side effects on something like that, even one of the more dangerous prescription level drugs, is minuscule compared to a 10 or 20% probability of having a heart attack or stroke over the next decade or two. And those are the kind of numbers that we're talking about. So, yep, I come on and I talk about a drug. I'm going to get a lot of haters. So be it. You got to know the facts. Fernando, getting on keto for about a year. If I drink a few beers, I wake up with high heartbeat. Is that an overload of insulin that I feel? I don't know, but I don't know. It could be some other things too. Alcohol in and of itself disrupts deep sleep, and it can cause some of this as well. Have to leave it at that. Weird Walker, Weird, it's been a while since I've seen your name. It's good to have you back. Can you commit on the recently released major trial out of Australia negating, excuse me, I'm getting a significant itch there, negating omega-3s and reducing cardiac events? I mean, zip, in direct opposition to the Reduce It trial. I cannot, Weird. I'd love to see that study. I haven't seen it yet. I will say this, you see this kind of stuff all the time. There was recently a trial published in JAMA, which was showing zero zip impact of intermittent fasting. I didn't trust that. One of the problems with that study was they were looking at weight loss. They didn't look at biomarkers, metabolic biomarkers. So, and I know that I experienced the same thing. Pardon me for transitioning over to intermittent fasting. The point to make, though, was weird that you and I both know you can get a lot of studies. That's what science is all about. Trying something, developing a theory, testing it, and seeing what comes out. And sometimes you get surprised. Don't go on one study. That's called a signal. When one study has one thing happen, that's called a signal. Never rely on just an individual signal when there's significant evidence in the other direction. Raise the question, continue to look. And you're doing the right thing. You're asking somebody who does this for a living. Pardon my itching. But again, sorry, weird, I have not seen the article. Joe Siliberto, CRP, a useful or not so much indicator? Thank you for your work, Doc. It is useful, Joe. It's useful for a couple of reasons that we talked about, especially for our patients with inflammatory diseases. That is the major inflammatory marker that their rheumatologist follows. So yes, I mean, we can't follow just microalbumin creatinine ratio alone. We can't, there are problems with that, kidney function issues impact it, things like that. We can't follow MPO alone. MPO is the most common lab false positive. If you leave myeloperoxidase, if you leave the blood in there for over 30 minutes before you spin it down, those white cells are going to break apart and myeloperoxidase is going to shoot way up. You're going to think you've got huge inflammation when you don't. It was just an error by the lab tech. The other thing is if the pipette goes down just a little bit too far in the testing process within the lab, it starts getting too many white cells in the tested amount. Again, it looks like MPO has shot way up. Very common reasons for false positive MPO tests. Microalbumin creatinine ratio, false positives associated with kidney function sometimes. Plaque 2, that varies based upon the actual kit that the lab itself used for testing. It also varies genetically. Some of us appear to, quote, run hot, just a little bit hot with plaque 2. And that's just genetically the way some of us run. So as you begin to see, there are problems with every one of those tests. And here's a great way to think about it. And medicine is not the only place that that's the case. But in medical school, if they tell you, well, we've got a panel, that means that there's not one single, simple, individual test. Good question. Thank you for asking it. I hope that dealt with it. Old Roscoe, what's your opinion of stents, bypasses versus medication for treating stable angina? We've covered that quite a few times. I think the last one was maybe last week or a couple of weeks ago. There are several studies that have come out. Stents, what was it? Was it the Courage trial, Orbita trial? Or in the Orbita trial, they actually gowned, they took a large part, this was in the UK. The US, they wouldn't agree to do it. In the UK, they actually took people that had, quote, clear indications, agreed upon indications for stents. They took them into the OR, they had them gowned up, they actually even put them to sleep. But at that point, they randomized them. Some of the people got stents, some of the people didn't. Guess what? The heart attack rate was the same in both groups, whether you got a stent or not. And oh gosh, speaking of haters, every time I bring that up, old Roscoe, I get a boatload of haters. And then I get the people that say, are you telling me my stent didn't help for my angina? It helped. I know it did. You're crazy, Doc. I'm not telling you, you or anybody else, that your stent didn't help. In fact, I know that some stents help. And in fact, if you look at the science, it's really clear. For example, with when you're having, that some stents help. If you're having a heart attack and they're able to remove the clot as part of a stent process, that stent helps. Do not pass go. Get that stent. But here's the thing. Do you know what portion of stents get put in to, quote, prevent a heart attack? 90% of stents. So according to the science, don't shoot the messenger. I'm just telling you what's in the science. New England Journal. This is not just a one study, simple research signal. This is the evidence. Stents don't help. They do not. Well, they help for heart attack. They help when you're having something. Stents do not prevent a heart attack. And that's in the New England Journal. It's in Forbes magazine. It's in New York Times. Stents do not prevent a heart attack. And guess what? There was some studies recently that all those studies left the whole, the interventional cardiology community scratching their head and saying, I'm not going to close down my clinic and my hospital because of this. We're going to keep doing stents. Unfortunately, too many people reacted that way. But here's the other thing that it did. There was not as much information about bypass grafts. So a lot of people started switching towards bypass grafts. And then there was a new study that came out just this past year called the ischemia trial. And again, you can look either of those up, any of those up. We're going to be actually putting a lot of that information on the website soon. Give us a few more weeks. That information is coming out. That information is, it's in the book that's coming out as well. That book is one place where you can get all of this kind of stuff regarding how to find plaque, how to measure plaque, what works, what doesn't. In the ischemia trial, again, pretty sure that was New England Journal, pretty sure that was last year, and very sure that it showed that the bypass grafts aren't preventing heart attacks either. When you think about the mechanism for what causes a heart attack, putting a stent in or putting a new tube, some new plumbing in, is not going to stop a clot from happening. Think about it. So, Joe Siliberto, indicator. I think your question was, is CRP a bad indicator? I hope I dealt with that question. Keith Rasmussen, thanks. Thank you, Keith. Appreciate the, smash that like button, if you will. Amir, thank you very much for the helpful information. Thank you for the recognition, Amir, and thank you for your recurring attendance. Erland FR, good to hear from you, Erland. Long time no talk to. According to Paul Ridker, his CRP is the test needed to determine severity of inflammation. His CRP measures the activity of IL-1 beta, IL-6, IL-18. Please comment on this. Yes, no question. Paul Ridker is a big fan of using, he just uses one indicator. He uses C-reactive protein. So one of the questions is, well, Brewer, I mean, you talk about Paul Ridker and you talk about all the stuff he's doing right, but then you disagree with him. You use 4 different CVI, cardiovascular inflammation indicators, and he's pretty commonly just using one. That's absolutely right. But let me just remind you, he's using one when he's doing studies of tens of thousands of people. So if I'm looking for heart attack progression over a 3-year period in a population of 20,000 people, when somebody gets an elevation of C-reactive protein because they got a flu shot, that is really not going to make that much of a difference in the impact of the findings of the study. I don't have those kind of numbers when I'm seeing one patient and trying to help you, and you don't have it either. I mean, if it's your numbers, if it's my numbers, we're worried about us. Are we as an individual in danger? So that's why we don't just look at one place and move on. We look at several places. There's a lot of false negatives as well. So There's a good reason to look at more than just C-reactive protein when you're treating a patient or when you are the patient. My a great question, Erlen. Good to hear from you. Thanks for the comment. My BJJ, have a happy Thanksgiving. I'm thankful for all you do to help others extend their lifespan. Thank you so much, BJJ. Please keep up the great work. And BJJ, you keep up the great work too. My BJJ is doing some work on an LP(a) foundation. We haven't gone down that discussion yet today, but as you might imagine, even though, we totally ignored LP(a). LP(a) is a genetic variation of LDL. You may have heard about it if you know anything about Bob Harper, the trainer on The Biggest Loser. Early 50s, obviously in great physical health, had a heart attack and collapsed on the floor. This was a few years ago. So it's like, this guy's in great shape. What's going on? And he appeared to have a good diet. Within a week, he came out and said, you know what? I've got significant LP(a) and I got it from my mama. So LP(a) is a big deal. The medical community has ignored it for the most part up until Bob Harper's thing. So therefore, if the medical community didn't tell any of their patients, then the patients didn't know about it. But more recently, over the past couple of years, a new drug has come out that is just a really big deal. It's a drug class called the antisense drugs. They're not quite ready for prime time, but they have a significant, as in 80 to 90% impact on LP(a). Can you get it? Not yet. Like I said, it's not ready for prime time. There's nobody receiving routine retail prescriptions for that yet. So what do we do for it? Number one, we manage all the other lifestyle components. Number two, one of the things that we see is significant decrease in inflammation when you get decrease in LP(a). Not so much with decrease in LDL and within normal parameters, but you do get it with LP(a). If you look at the AIM High study, you look at some of the other HPS2 Thrive, a bunch of the other studies, they'll say, and the whole American community used to give niacin for LP(a) because it decreases it. It's the only thing that we know of in terms of a supplement or a drug that will decrease it, besides the new antisense drug. You used to take that. I still recommend it for my folks because I have a different viewpoint. I'm able to see that even though the niacin typically only gets a 30 to 40%, 25 to 40% decrease in the LP(a), you do tend to get decrease in inflammation associated with that. So I take niacin. I have a lot of folks taking niacin. As I said earlier, niacin, vitamin D3, and vitamin K2 are my three most commonly prescribed supplements. ESL, hi from Argentina. I've got a few folks from Brazil, but I don't remember having anybody from Argentina. Thank you so much, ESL, for letting us know. Thank you deeply for your generous sharing of knowledge. Thank you for acknowledgement. Mr. Y. Tully, hi. How does high iron, ferritin around 400, normal 440 to 380 affect the vascular system? Too much iron in the transferrin, too much yes, that's a problem. There's a video, and I did it because I was very interested in it a while back. I love cross-country skiing. And there was a guy that just totally wiped out the cross-country skiing records. And if you go back, it was interesting. The guy, the journalist that wrote the article about this guy went to one of his family reunion events. And about a third of the people in this family reunion event had this dark, musky, almost tan-looking skin, as did the guy that had all of these cross-country skiing records in Sweden. So here's the rest of the story, and here's the connection on that. He had a genetic version of increased red blood cells. It's one of the versions of what we call polycythemia. Poly meaning too many, cyth meaning cells in the blood. It's polycythemia. So he had a major advantage in terms of ability to transport oxygen. Now, it was, again, a genetic thing. But here's the problem. even though it gave him advantage in terms of athletic events, having too much iron is very much associated with heart attack and stroke risk, and yes, inflammation. Stanley Dace, I started taking vitamin K2, MK7, and D3. Are they helpful? Yes. Like I said before, those are two of my 3 most commonly prescribed supplements. Mr. Y, Tully, keto, paleo tend to be lower in fiber. How does fiber affect your lipid profile and inflammation? Fiber actually does decrease, it improves the lipid profile. I take fiber every day, Metamucil. Now it's not a Metamucil, it's psyllium fiber. It's the stuff that you find in Metamucil. Psyllium fiber, you can get it. The problem is Metamucil and most of these other things come in these little caps. And if you read the directions on it, it's talking about taking like 4 or 5 caps 3 and 4 times a day. What you should do, and I do this, I just get this big bulk bag of psyllium fiber, and I put it in my my 0-calorie smoothie every morning. You got to watch that. It turns a smoothie into more of a pudding. And as you might guess, yeah, I mean, I've got a video on that smoothie. I've made a few adjustments, but I've got natto in there for K2, natural K2. I've got a lot of different things in there. It's not for the weak at heart. It tastes awful once a day. Anna Garrich Malley, I'm sorry about the pronunciation. I agree with you. What we did lately just cut carbs too low. I think that sugar's the biggest problem causing inflammation. Do you agree? All the best for you, and thanks for your information. Thank you. I do agree that it's not so much just sugar in the diet. A couple of things I would clarify on. It's not so much sugar in the diet. The vast majority of problems I see in diets doesn't come quite so much from sugar as it comes from grain products, pasta, pizza, beer, and again, breads, pasta, pizza crust, grain products. And you know what grain products have? You call them complex carbohydrates. A complex carbohydrate is nothing but a chain of hundreds, thousands, millions of little sugar molecules. And you say, well, the assumption is, well, with those little sugar molecules, it takes the body a long time to break them up. Look at the glycemic value, glucose in the blood value of, quote, whole grain bread. What is it, like 70? When a teaspoon of sugar is 60. Quote, whole grain bread, whole grain products, even worse. So be very careful about the assumption that it's really just sugar. And be very careful about the assumption that, oh, if it says whole grain, then it's got to be healthy. Be very careful. Heather Armstrong, thank you for sharing this information. You're very, very welcome, Heather. Thank you for the acknowledgement. Eric Bobadillo, thank you for very informative. Thank you, Eric. Uh-oh. We're still getting a lot of comments. We're getting, I usually try to cut this off at about an hour. Got a lot of interest today, so I'm going to try to get, I also usually try to get through the questions. I think we can if you, let me look. I'm going to try. I'm going to need to blitz, though. Heather Armstrong, is cholesterol more of a consideration for someone with at least one copy of the ApoE4 gene? I've seen others recommend avoiding eggs and red meat and dairy if a person has that gene. You do. A lot of people say, well, you can't handle fats. David Wright, who's a very good physician in this area, and I are currently having a little bit of a pseudo debate regarding what's really more effective for an ApoE4 person. Is it keeping some ketosis going on, and therefore, driving, again, you can't keep a lot of ketosis going on if you're living off of carbs. Or, which is it? If you look up Dale Bredesen's book, for example, he'll continue to hammer on, ApoE4 is a big deal for dementia, and he would hammer on maintaining that ketosis, low level of ketosis. Frankly, my vote, I think he's right. I think it's healthier, even for an ApoE4 person, to maintain some ketosis. At the end of the day, I got a lot of patience with this, and you end up having to tiptoe through this. In other words, you have to look at a balance. James Cantor just came in love. Is there just one test I can ask my doctor to do for inflammation? Is it C-reactive protein? That's the one. If the doctor's only, if they'll only give you one, that's the most common one. I would personally rather look at the functional one if I had only one, the microalbumin creatinine ratio. Just came online. Oh, okay. Got it. Thanks for the correction. Bart, good question, Heather. Hope I covered it. Sakura Sumo, curcumin. Sakura, I'm guessing you just came in. We've had a good bit of discussion and at least one comment about curcumin. Curcumin is great for inflammation. And thank you for sharing. Acuna matata. Is sirtranol effective or just a hype? I'm not familiar with sirtranol. I wish I could answer that question, but I can't. Got Bob Weiss, good morning, and good morning to you, Bob. Osei Shalom. Sakurosimo, yes, ginger tea and curcumin are anti-inflammatories, to name a few. Always assume you have NAFLD if you were born in North America. For those of you who don't know, that's non-alcoholic fatty liver disease. I have to tell you, Osei, I do not give fatty liver disease enough airtime. I've got several videos on it. It's a big deal. Kevin McCord, who's a doc that's worked with us a little bit, and hopefully will be working some more with us, has a major focus in that area. You're right, it's a good reason to have that. Guys, it's getting a little bit late. I am sorry. I don't think we're continuing to get a lot more questions. I don't think I'm going to be able to get to them all today. If you'll put the questions on the, there will be a replay. This will go into YouTube. It'll be recorded. You can listen to the replay. If you'll put and we'll take the actual program component out and publish that alone, as well as a few of the questions. If you keep an eye over the next few weeks, if you'll just add your question to the comments below the videos, we try to get to all of those. Again, we can't get to all of them, but thank you again so much for your interest today. Well, we had a lot of interest, didn't we?
Yes, Doc.